Well, thank you for that, and thank you for our presenters. Three very provocative presentations. So just a very small bit about my own background. I may well be the only person in the room that actually has not been doing comparative effectiveness research. In fact, I've not been studying therapeutics at all, except accidentally occasionally. But I come from a background in which I've been interested in upstream causes of morbidity and mortality, mostly in the workplace. And it turns out to have prepared me very well for a lot of this discussion. Because three things are true about the environment in which most of my life work has gone on. One, the first is that you can't do clinical trials for practical and ethical reasons. So we're in a clearly observational space. The second is we have extraordinary and very conspicuous selection pressures in the populations coming in and going out. And quantifying and managing them methodologically are very problematic, but they're visible to the naked eye in many ways. The unobserved that most of us are dealing with in making bedside decisions represent some form of asymmetry of knowledge and information. And in the work environment, again, we have better grasp on what some of those pressures may look like and how to identify them. And then the third issue is that it's been very clear just from simple observation, forgetting even formal methodologic observation, that there is substantial heterogeneity in the way people respond to the work environment. And it's visible to the naked eye. It does not cleave along typical bedside things. It's not necessarily related to age or race or experience or lack thereof. But it's obvious to virtually anyone that's ever performed or practiced health in that environment that heterogeneity is surely the hallmark of the diverse responses that people have to adverse physical elements in the work environment. So it's very good preparation for this. And with that background, I'll come back to it in a second. I just want to comment on a few of the things that I heard earlier and then in the last few minutes. So one distinction that I'm actually surprised no one alighted on in terms of thinking about the scope of our problem is in terms of the questions we're asking is I think as a simplifying rule that we can break down the kinds of questions we're asking into those that involved a single point of care treatment choice. Surgery, no surgery, stenting versus cath, do you operate or do you waitfully watch, whatever. That's made at a single point in time for which, thankfully, all of the concerns that Jamie and Miguel and others have raised about the need, even in a trial environment, to have some form of marginal structural model to deal with time-varying changes that occur over the course of observation. And then we have those that, in fact, have all of those problems and in which observational research, and I think I'm inclined towards Miguel's view, that observational research and clinical trials have a great deal in common. But the former, which certainly serves the example of Mark's well-presented studies and fascinating studies, do actually form a setting in which we frankly don't have to worry about those complexities. The real issues in dealing in the observational domain are ones that there's been a fair amount of discussion about and which get quickly to the area that came up in Dr. Basu's discussion, namely where and how we use instrumental variables or other strategies for trying to effectively randomize in an environment in which randomization is not going on. So there's another distinction that I want to make, and then I'm going to come back and finish by talking a little bit about the application of IVs to try and tease out better some of the heterogeneity in the population, and that's to comment this that I think that despite my experience in the work environment and the obvious heterogeneity in response, the real problem that we're having in looking at these larger study populations is to some extent conceptual. I mean, we have bought in this crowd to a very stochastic way of looking at questions of whether something it has efficacy or whether it doesn't, which is based on a certain set of assumptions, which in essence, we're not averaging over all kinds of different effects. What we're imagining is that those effects are in essence random, and we are exactly trying to decide what the average effect is. We're not thinking yet about about effectiveness and what we're going to do with the information, but we're suspending belief about biologic differences for a moment in the very means we use to decide whether or not a particular drug or agent works at all. And that's a stochastic view. Many of our colleagues, not represented here, but often in other parts of the academies, don't take that view at all, but live in a very deterministic world in which they would imagine the only thing interesting about heterogeneity is how much we do or don't know about the underlying biology. And if we understood the biology, what are you talking about? So for example, nowadays, and cancer I think is the happiest place to talk about it, we no longer talk about breast cancer patients as breast cancer patients. We don't stage them the way we did when many of us were training. We talk about them in terms of their receptor pattern, and we don't for a moment imagine that people with triple negatives are going to respond the way estrogen positive patients will. It's not even a question. It's off the table. And the data, of course, conforms to that. But we've given up on the stochastic view because we've now got a biological basis for dividing the population. We talk about them as totally different phenotypes. And so one might imagine that the day will come for cardiovascular disease where we'll have a similar discriminatory pattern. I'm not wildly optimistic about that, but that will certainly solve our problem if we start seeing cleavage along those lines. I can tell you from my experience in the workplace that don't expect it to conform to the categories, the demographic categories, or the simple, racial, sex, and so forth differences that we usually would do, for example, the kind of analysis that Mark just elegantly showed us in looking for subgroups. Now, one area in which we might do that kind of subgroup analysis for which there's a good underlying prior is for people that have unique pre-existing diseases. So for example, when we start looking at the notion of our diabetics responding differently from non-diabetics, even though we don't have a completely coherent theory about that yet, it seems extremely plausible from other experiences with different populations, things that have been obvious to surgeons for years about how a diabetic patient is likely to do under various conditions, that probably will carry through to a lot of our interventions. But I think those are the lines at which we're going to start seeing this heterogeneity and in which we can perhaps adopt a more relaxed view of the kind of specific evidence that we would need, in which we so overcorrect for multiple comparisons and so forth that we actually do what Peto has done for years, which is effectively abandon any interest in or hope of identifying important subgroup heterogeneity. So I want to make one final comment, and that relates to just a practical application, which I was introduced to in the only good way one gets introduced to things by a student, who has been looking at various forms of observational data and trying to find ways that instrumental variables could be very practically applied and might even turn out to be useful for looking at heterogeneity. And it's actually a combination of the sort of the propensity score type approach that Mark used, and which I worry about because it doesn't necessarily get at the single worst unmeasurable thing, which is endogenous differences in doctor and patient preferences, but combines it with an instrument. So the basic idea is that when the study was actually briefly showed earlier this morning, in which he developed this method. Mike Biacchi is the name of the student. And it was looking at the outcomes from newborn intensive care unit, from newborn ICUs. The instrument was basically proximity to the unit. It's a very simple instrument. But the way he did the study wasn't just by applying the instrument, which turns out to be moderately weak, but by doing the following form of near-far matching. So he basically took his entire population of infants at 2 hospitals in Philadelphia, disparate, physically separate areas, took the entire population that had used the hospitals over a period of time and meticulously matched them on everything observable, and took people in pairs that were virtually identical at everything observable except for the one thing that was his instrument, which was distance. So he looked for people that were as similar as possible in every observable variable and as different as possible on his instrument. He threw out a lot of people. There were a lot of people that could either not match other individuals or turned out to live kind of between the 2 hospitals, so they didn't add very much. So with a subset of those people, he was able to define very sharply the enormous benefit that CHOP, which was the study hospital, actually conferred. And what's nice about the way he did it, although he hasn't followed it through yet, but is working on it, is that this allows him actually he could do exactly the same thing within subsets of this group. So for example, he could do a subset analysis if there's sufficient power of a particular subset of high-risk mothers or a particular subset of high-risk infants to see whether or not the same effect is seen. It's nice because I think causal inference is strong, and it's actually very practical to do. I mean, it's quite simple to do. Anyway, I'll stop there.